Okay, let's get started then. Welcome everyone. Great to see so many of you, and I think we've got some more joining. Although inevitably with this time of year, school holidays, it's always difficult to know once you accept an invitation, you may not be able to make it. Okay, so please feel free to introduce yourself in the chat. And can I just do a little prompt here for our member survey? We've had 20 responses so far, and in particular, we're monitoring questions about the quality of the NHS and voluntary sector relationships, and optimism or indeed pessimism about the future of Thames Valley ICB structures. When we started doing this monitoring in mid-2022, the quality of the relationship was 5.4 out of 10. And the system working outlook was 4.1 out of 10, meaning that people were more pessimistic than optimistic. Now, it was a quite short survey, so please do click on it and complete if you'd like to, either now or afterwards. Let me take this opportunity just to thank all the people who put time into the Alliance, the whole steering group, which includes our place-based leads and the local infrastructure organisations, and the co-chairs of all the action groups and community research network that we support through the Research Engagement Network. We also really want to thank BOB ICB, who continues to support our Alliance, because they genuinely see the value in what the wider voluntary sector does and want to benefit from your insights and understand how you generate impact alongside what NHS organisations and professionals delivered. We've just renewed our MOU with the ICB into 2026. And I think it's important to recognise that not every ICB around the country has had the level of support and engagement that we have had with BOB. So this meeting is built on the partnerships that are already alive between the NHS and the voluntary sector. In the papers, you'll have seen 7 short case stories. And in the first session, we're going to call on some of the people who wrote those to say a few words about the partnerships. But to begin with, let me introduce Dan Levinson, who's Director of Places and Communities with the ICB. And I hope Dan will be able to set the context for us for the rest of the meeting, recognising that while more change is coming, we still have the current place structure to work within, and hence are giving opportunities to kind of for a more detailed discussion about that in the breakout groups. Dan, over to you.
Yeah, thanks very much, William. So, like William said, I'm Dan Levinson. I'm Director for Places and Communities. So I work for Bucks, Oxfordshire and Berkshire West Integrated Care Board, BOB ICB from now on. Like William said, so our current configuration with 3 very unique places with the kind of different configuration of local authorities, different partnerships. My job is to really oversee the development of those place-based partnerships, and I'm really happy that William referred to the strength of our relationships and the surveys asking about that, because really that's the emphasis for how we're building our system, how we're working in partnership and things like that. So hopefully that's a theme that runs throughout. I think it's fair to say we're on a constant kind of carousel of change at the moment. Obviously, we have the NHS recent announced changes to NHS England and the Department of Health, the integrated care boards reducing and forming into, so from 42 to 26, and us becoming a bigger footprint with less capacity and more focus on strategic commissioning. There's the local government reorganisation in Oxfordshire and impacting into Berkshire West, and then a progression towards devolved local authorities, so local strategic authorities in the future. We've got changes in social care underway with the Casey review, and changes in children's services, and we've had our recently published 10-year plan. So it's a constant change, and that's the system that we all work in. Alongside that, if we think about what the demands that we're meeting, we're constantly trying to meet increasing demand and complexity. I think that's the same whether you work in the voluntary community sector, whether you work in the independent sector, the care market or NHS. Everyone is seeing growing demand and complexity, and within a context of financial constraints. So we don't anticipate more money coming. So what we do, we have to do within the envelope of funding that we have. And the backdrop of that is really a decline in public satisfaction. So people should have high expectations of all of our services, and that's quite right. And at the moment, we're probably not doing everything we can to meet those expectations. And then I think what we'll see today, and hopefully we've got a good few hours to get into it, so I'm really excited about what was in the papers, is the value and the role of the voluntary community sector within our system. And hopefully, like William says, we've seen over the course of the last couple of years how important our relationship between statutory organisations and the voluntary community sector is, and the value of that, particularly as we begin to deliver, hopefully people have read in the 10-year plan, neighbourhood health and care. So much more focus on what's in communities, how we can coordinate and use the assets that are around people in their homes that they live in, the communities that they spend their time in, with the neighbours and friends and families that they have. And the role of the voluntary community sector within neighbourhood health and care cannot be underestimated. And I think what we'll see, hopefully, through the course of the next couple of hours, is we're building on really strong foundations that have been set in Buckinghamshire, Oxfordshire and Berkshire West with the work that we've done over the recent years. And I think our success will be determined by what we do from that foundation. So I'm really excited about what's to come. So thanks very much, William.
Okay, thank you. Stephen, over to you then.
Good morning all. Thanks, William. I'm Stephen Barnett. I'm the director of the BOB VCSE Health Alliance, and I'm going to lead us through about a 15-minute session where we'll hear from some of the people who submitted case studies that are featured in the papers. The idea of this is that in the past we've done a lot on the principles of the voluntary sector working with the NHS, and we wanted to remind ourselves that there are existing partnerships that are quite deep and quite varied between the NHS organisations and voluntary sector organisations in our geography. So these aren't presentations or explanations of the partnership. They probably only make sense when set alongside the written case study that's in the meeting papers. So what we're going to do is first going to hear from a video from one of the leaders of a partnership, which is about domestic violence referrals from a hospital to the Alana House charity. Then I'm going to put questions to Catherine Warner, who's the person who runs that referrals process for Alana House. Then we're going to go to a different case study with Matthew Green and Vic Latchford. Then a different one again, which is a very local sort of neighbourhood health themed case study with Jules Pritchard and Michelle Bewley. And we're going to finish up with Dan Levison, again with Laura Price on the Well Together work that's being done in Oxfordshire. So let's do the little video from Joe Horsborough from the Royal Berks first.
Hi, I'm Jo Horsborough, Head of Safeguarding at Royal Berkshire in Reading. I'm really sorry I wasn't able to meet your meeting today, but I've just got a few words to say about this really unique partnership between Alana House and the Royal Berkshire Hospital in Reading. We've been working together now over a couple of years and we've continued to grow, enabling our patients who present with domestic abuse to feel safe and know that they will be supported when they are discharged. Our staff at the Royal Berks have developed a good trusting relationships with the team and a shared understanding of the complexities involved around domestic abuse. Knowing that we can access this valuable service at a time in someone's life when they feel the most vulnerable allows our staff to feel confident in caring for our patients, and we thank Catherine and the Alana team for all their support and ongoing work.
Wonderful. Okay. So let's bring in Catherine Warner and we can spotlight Matthew and Vic and all the others as well. but we'll come to Catherine, who is there first. Hi, Catherine.
Hi.
So what's your perspective on the partnership with the Royal Berks and the work that you do?
So yeah, one, it's really positive in terms of the relationships we've built with the staff, but also it complements and strengthens our safeguarding offer for those patients that are identified as at risk of domestic abuse. So we've streamlined our referral process, so all it takes is a phone call. So all we're asking for the hospital staff to do is identify potential victims. And then our skilled and trained staff are popping up there because we're 5 minutes away, and we can meet those patients, seek a self-referral because all our services are consent-based, and really strengthen what the hospital do. It doesn't remove anybody's safeguarding responsibility. So obviously they would take their responsibilities if they've identified risk, but we can also work with that patient, and also we take safeguarding and risk mitigations where we have information from that patient. Ultimately, we're tracking those patients to see if we can also reduce the demand on the front door. So ultimately, our goal would be to reduce the incidences of domestic abuse, and therefore there's less likely that they'll be turning up in A&E. But what we have seen is also those patients are engaging more proactively with other health care, so actually in a good way. So actually in terms of maternity services, we've seen patients where we're supporting them to access health, and making sure that's really appropriate for them.
Wonderful. Thank you, Catherine. And I'm conscious of, we're just doing quick spotlights on case studies that are actually really interesting. And probably what you've said has raised lots of questions, but we're jumping from one to another. So the next one we're going to go to is Matthew Green and Vic Latchford. So Matthew, also from RBFT. Can you just tell us about how Citizens Advice helps employees of RBFT?
Yeah, thanks, Stephen. So I'm Matt Green. I'm the staff wellbeing lead. So this is from a staff angle as opposed to patients. We've got an extensive range of staff wellbeing support available in the trust. The big thing for me is having a link with a reputable external organisation that can really drive forward to our staff communities most in need. And the really big partnership is where a lot of our services will offer signposting. The brilliant thing about Citizens Advice is they can actually do the end-to-end solution, and really with the complex cases get involved very thoroughly and very heavily with staff, and having that one-to-one interaction on site has been a real big bonus for us.
Fantastic. Thank you, Matt. And Vic, what's your perspective on the partnership there?
Yeah, it's been an excellent way to actually work along with Matt and his team, and they've done a brilliant job of promoting the service to all the staff at the RBH. We've really been able to engage, and there may have been barriers before for some of those people to actually access advice and signposting, but because we've been on site and we're there regularly, people know we're there and have been coming in and seeing the team, and we've been able to refer into our teams for more complex casework needs, but also signpost to other external voluntary organisations all over Reading and Berkshire as well for a different need. So we've felt it's been a really beneficial partnership all round.
Wonderful. So I sort of also picking up both from Catherine's and your case study that there's one referral tends to lead to lots of other referrals and increased access to different services. It's an interesting little theme. Okay, we're going to jump over to Michelle Bewley. By the way, Michelle, I couldn't see Jules Pritchard in the meeting.
That's correct. She sends her apologies. She's
Right.
dealing with a faulty fire alarm that's going off. So
Right. Okay. All right. Michelle, tell us about your partnership from a social prescribing perspective with the community centre.
yes, thank you. Thanks for inviting me. We were approached by a PPG to run a health event. And being a social prescriber, I'm in touch with so many VCSE organisations. So I spoke to Jules, who's the manager of Hazelmere Community Centre, which is a local asset. It's trusted by people. They run lots of different types of groups. We signpost patients there, lots of different cohorts. It's a very safe and trusted space that's well known with the community, and ideally placed to host 27 organisations, which actually all turned up on the day, which is amazing, to showcase their offers to the community. So working closely with Jules, I was able to network, connect other organisations together, and have a footfall of about 400 residents.
Hello, could I get a small white Americano?
And a small white Americano.
You can possibly get that at the community centre.
Yes, if you excuse the fire alarm. So yeah, it went really well actually together. We worked well together, and we plan to run more events and get more organisations into the community centre. So it promotes the community centre, and it promotes the offers that other organisations can offer our patients and our residents.
Wonderful. And can you say what you think Jules would have said? What's her perspective on hosting the kind of event that you did?
Sure. Well, Jules was really pleased with the footfall. They have the Hazelmere Fete, which attracts so many people, and again, charity organisations have stalls there, so she can promote that. And working in partnership with us, it promotes health, and it's what the Hazelmere Community Centre likes to do as well. Promote social health. So it connects everything together, really. It just glues us all together. And I think the charity organisations also got a lot out of it as well. We've had lots of good reports. So all in all, it was a win-win for us.
Thank you, Michelle. Now we're going to go on to Dan and Laura. And I also wanted to say thanks to Emily Lewis-Edwards, who works with, whose organisation, Community First Oxfordshire, works with OCVA and NHS local place partnership as well. She actually helped me with the case study while Laura was away last week. Dan, how does the Well Together project complement local NHS services by working with charities and community groups?
Yeah, so Laura and I haven't actually rehearsed this, so hopefully I don't say all the things that Laura is going to say. But in reality, so this program's been running about 2 years. We used we had a small amount of ring-fence funding for prevention and health inequalities that we've been able to allocate, and we were quite determined from the outset that we wanted to focus on the core 20+5 population. So that's the 20% most deprived populations, the people who are marginalized or minoritized that have the worst outcomes, so the people that experience the most inequalities, and those 5 clinical areas, so things like cardiovascular disease and respiratory. That's the first thing we were determined to do. The second was we were determined to work with voluntary community sector and grassroots organizations. And what's been really great about it is we've been able to, or by the time we finish the programme in November, we will have distributed £1 million into those grassroots organisations in the most deprived areas. It's been totally bottom-up work. So unlike most of the things that we do in our organisation, where we tell you how to do it, what form to fill in, which things to do, where to go to get it, we've asked the communities what will make the biggest difference to their health and well-being. And as a result of that, I think we are better connected with those communities. We've had the University of Oxford that's done some work that's demonstrated we've built social capital and networks within the communities themselves. And as an organisation, I think we're learning to be much more culturally competent. And I think those are the things that will make what we do in the future to address people's health and well-being sustainable. Hopefully I haven't stolen everything that you wanted to say, Laura.
Really good. Okay, Laura, what's your perspective on that partnership?
Yeah, no, thank you. I think probably the first thing to say is that money's not everything, but it does unlock a degree of respect and trust. And I think that fundamentally putting some money on the table really helped to kind of get those conversations going, and for communities to feel that they were being seen and recognised by NHS partners. I think the other point to make is that Well Together has been a really iterative programme. It's very much built on work that's been done by Oxfordshire's public health team and the community insight profile. So we were really keen to build a programme that wasn't standing apart from what was happening in local government, that it really was a system approach. And then I think the other thing that Dan referenced is that the key has been that alongside the money that enables the delivery of the activities that reference back to core 20+5, there was also funding for grassroots community development support through community capacity builders who were already part of those communities, but could help and support those groups to understand, you know, how they could accept that money, how they could develop those activities. And the Oxford University study has really emphasised the importance of having those people embedded in that community to walk alongside people developing those activities. So I think that's really helped us to enable a series of activities that help communities to articulate what they want to do that isn't a medical model, but very much helps to support their health and well-being. And I think it's really developed the understanding around that.
Perfect. Thank you, Laura and Dan. Thank you all for joining. And thanks to everyone who submitted a case study. I'm sorry we just didn't have time to be able to fit everyone into this little spotlight session, but I also wanted to say thanks to Connection Support and Oxford Health for featuring their case study about embedding housing workers at Warneford Hospital, to Sport in Mind and Berkshire Healthcare for featuring their physical activity programme for people with severe mental illness, and to Florence Nightingale Hospice Charity, which shows how the hospice charity contributes funds to palliative and end-of-life care in Florence Nightingale Hospice. Right, I am now handing back to William.
Oh, thank you, Stephen. Okay, this next bit is looking very much at how these partnerships might relate to 3 Shifts 10-year plan. Maybe it's a big ask at this point, but let's see what we can do. Also, what kind of leadership is needed for partnership working? I think that's a critical question. And how does all this fit into the changing role of ICBs? So I'm now going to come to each of the 3 chief officers. Rachel, who's the chief nurse and exec lead for Buckinghamshire. Matthew, who's chief delivery officer and exec lead for Oxfordshire. And Ben, who's chief medical officer and exec lead for Berkshire West. So Rachel, you want to have first go, just reflecting on these and the other case studies and questions. You know, what do you think we have to learn from these partnerships?
Thank you, William, and thank you, and thank you for asking us to be here. What a fabulous way to spend our Tuesday morning with partners and colleagues across the system. So thank you, William. And I don't know if colleagues saw in the chat, but just listening to some of the case studies that you spotlighted earlier, I think really highlighted to me the impact and the benefits of this partnership working. And I saw firsthand actually the work that the ARC, PCN and the social prescribers do down in Hazelmere about 18 months ago, actually not long after I first started in my role. And you know, the value that you and your colleagues in the partnership brings to making such a difference to our local communities was phenomenal. So going back to the task in hand, and I've put some thought to the questions that you've posed to us, William and colleagues. So for colleagues that aren't aware, the 10-year plan has set out some really big ambitions, you know, a real challenge for us as leaders and providers and commissioners of health and care services going forward into the next 10 years. But I think all of us would subscribe and sign up to what they're setting out for us to try and do around shifting much more to prevention and proactive care, from seeing a real shift from analog to digital, and from enabling us to provide much more care close to home. And I think all the case studies we've heard and have read about this morning are examples of that. So in response to that first particular question, I think our VCSE partners really enable us to be much more upstream, much more early on with connecting with our local communities, and often those that are furthest from our services that they need to access. And I see that, and I think the case studies really illustrate that firsthand. What we're trying to do, and I think through that enabling of those shifts, is to create system working and move away from what I think has historically been siloed organisational structures, where we come together and share those outcomes and share those resources. And again, I think we've seen that coming through in these case studies today. And I know when I spoke to Kate working in Bucks a couple of weeks ago, we were talking much more about how the VCSE is able to really lean in and bring our partners together so that we can really tackle and address what we're trying to do around reducing inequalities. And I see the partnership being a real enabler to us having those communities, our partners, holding us to account, holding each other to account for that decision making, and taking down some of those structural barriers, some of those organisational barriers that prevent us from tackling some of those inequalities. So that's my kind of 3 points, I guess, in response to that first question. In regards to the second question, what kind of leadership is needed for partnership working? So I think 3 things for me. So we've touched already on that system leadership over positional and kind of organisational leadership. So how do we work together? I think one of the things that all of us get such joy from is being brave, being courageous, and functioning with a little bit of humility. So how do we genuinely listen? How do we acknowledge? How do we share the things that we need to do? And one of the best things I love about working in systems is that relational leadership. So some days I feel, crikey, all I've done today is talk to colleagues, build relationships, work hard on engaging with partners. And I think that relational leadership is really fundamental. And then thirdly, in response to your last question about how does this fit with the changing role of ICB? So I see, and often we talk about what value do we add, what difference do we make as an integrated care board, and what's our role? And often it is about bringing partners together, convening, enabling those system partners to come together and provide some of that transformation, and sort of unlocking some of those barriers that perhaps have been in place before. So they're my starter for 10. Really hope that gives Matthew and Ben opportunities to build, welcome questions and challenge on some of that, and look forward to the debate playing out over the course of the next few minutes. Thank you, William.
Okay, thanks, Rachel. Ben, you're next.
Thanks very much. So just getting off mute there. Hi, everybody. Yeah, just to echo Rachel's comments that it's great to see so many people here today and all those examples. And it's fantastic in a way that you had so many case studies that you couldn't include them all. That's much better than having the opposite problem, really, isn't it? But yeah, I suppose I'd probably draw out 5 themes from the 10-year plan that sort of are very relevant, I think, to the role of VCSE partners and also illustrated, I think, in the case studies. The first one is actually as delivery partners in the delivery of neighbourhood health. The plan's very clear that VCSE partners will be embedded in integrated neighbourhood teams, and we've already seen examples of where that's already started to happen. And I think really adding value to sort of some areas where health services traditionally aren't so well set up. So things like, you know, to do certain functions like deliver social prescribing. I think some of the support for mental health in the community, and that excellent example in the case study of getting people more physically active as well. Rehabilitation, recovery, I think, from traumatic incidents, and advice on things like debt and housing issues and so on. And I think the VCSE sector sort of brings more focus on that wider sort of perspective on the social determinants of health, really, which benefits us in the health side, sort of service side of things, because of it sort of frees up the capacity as well. In terms of the leadership part, I think there's a really important role in the contribution as strategic leaders and partners in the integrated care system. There's going to be more focus on a more strategic approach to commissioning, and the 10-year plan does set out how VCSE organisations will be included in that, both in terms of decision making and service design, and that I think would happen at all levels, so neighbourhood, places and system levels. And again, I think that will bring a sort of welcome extra focus on tackling health inequalities, how marginalised communities are represented, how we make sure that services are designed in a way that reflects the local needs as well. I'd also add to that, though, that there will be need for sort of longer term funding, I think, arrangements and things to provide that stability that partners will need to be able to actually undertake that role in a sort of sustainable way. There's also examples of how volunteering, I think, will be helpful. So, and again, there's an example of the case study around how this actually directly supports the NHS workforce, such as the one we just heard about, how NHS staff are being supported. And then I think there's also a big theme in the plan. One of the shifts is around the drive towards new technologies and digital technology. And again, I think particularly for underserved populations, VCSE organisations can play a really helpful role in reaching those populations and helping them to adapt to this new way of accessing healthcare. And I think there's gaps there around sort of digital health skills that could be filled, but also health literacy more generally, because it's one thing for someone who works in the NHS to access some of these digital technologies, such as getting online health support or advice from your GP, but it could be quite a different thing for someone who's not familiar with using those sorts of approaches, really. And then finally, I suppose the last thing is just the whole resilience of the system is strengthened. Again, I think if VCSE partners are more involved, and there's also that extra focus on prevention as well. So yeah, lots of benefits.
Okay, thank you, Ben. Matt, you've got delivery in your title, and we've got lots of aspirations in your plan, and Ben's been reflecting on some of those.
Yeah, absolutely. Morning all.
How do we actually make sure all this works?
Yeah, Matthew Tate, Chief Delivery Officer for the ICB. So I'm not sure I wanted to go last with my colleagues. They've been very eloquent in some of their articulation of the question, but it's just to perhaps build on a few points. So I think in terms of the shift, I think from hospital to community, I think it's clear from all the case studies that the voluntary sector give us such wonderful insight. They're much closer to the communities than the institutions that we're involved with. They understand the drivers. They can direct and coordinate around that. So they're absolutely fundamental to that shift and understanding that. And as Ben and Rachel have indicated, that link to neighbourhood health, some of the work done, I'm thinking particularly of the Well Together and the Bucks work around targeting the particular areas of health inequalities. That really is the foundation of where we should be focusing our neighbourhood health development. So really important we build on that. And I also like the fact that some of the initiatives are based on staff. Ben mentioned this, but actually we need to remember how many people the NHS employs. They're all part of our local communities and have some of the same struggles as everybody else. So I think it's really important. I'm really pleased to see that link to staff in some of the case studies as well. I think the analog to digital one is interesting. I wouldn't mind some debates about that in the breakout, because I don't think you quite see so much of that in the case studies. So I'd be quite interested in the wider perspective of the voluntary sector around the opportunities, as Ben's highlighted, to step into that space, or if it's just a space we don't quite understand how vibrant that is in the voluntary sector. I think it's worthy of debate. Leadership, I think colleagues have mentioned it. It needs to be collaborative. It needs to empower. I think we always need to be conscious, and we need to break the power imbalance between the organisations in this partnership work. And it's so evident that there is a power imbalance in the size and shape of organisations, and we need to make sure that our leadership style just breaks that, and that we are and operate as equal partners. In terms of the changing role of the ICB, I think that it supports the model in a number of ways. So if we think about our new role, we need to be better at targeting intervention. We need to be better at understanding our data to do that, to make sure we're really focusing on our population that needs the support. We need to be better at focusing on outcomes rather than on process, which I'm sure the voluntary sector colleagues will support, because we can be overly bureaucratic as organisations in terms of our oversight, our KPIs. We need to really focus on outcomes. And I think if we're going to operate on a smaller footprint with less people, we need to empower more, and that's empower the partnerships, including the voluntary sector, to do more delivery with less oversight. And just to build on one of Ben's points, and probably my point that I always raise at these events. If we're strategic commissioners, surely we can crack long-term funding. That's an absolutely strategic point. We haven't done that well so far, I don't think, over the last 2 or 3 years. I think we should be continuing to challenge ourselves on moving some of our non-recurrent money to real recurrent funding for our VCSE. I think we can do much better there. So that would be my reflections, William. Hopefully that's helpful and stimulates some debate as we go into the next session.
Okay, thank you for that. If we can just, we've got a bit of time before we take our break, so if we just reflect a bit on some of that. Matthew, as you would expect, I think particularly interested in the point you're making about power imbalance, which is clear. The importance of longer term funding. I think all those things are really significant. But I guess what that feeds into is knowing that partnership working is a challenge. What sort of attributes do you think we all need to have in order to make that work? That's not just for you, Matthew. Anyone else can comment, but you want to kick off?
Well, it's interesting, isn't it? Because there's lots of attributes. But one of them, I think we need to have resilience around making our point and arguing a corner. And I'm thinking, even within the ICB, we've had a tremendously difficult financial planning round, and actually the work that the team, and particularly credit to Dan and the team, to sort of demonstrate the not just the impact, because actually we know that it's difficult to measure the impact of some of these schemes in a short time frame, but the principles of empowering and the bottom-up support. So making the case for that time and time again in very difficult financial circumstances. So I think there is something about being the champions and standing behind our convictions, even when it gets really difficult, which it will continue to be, as Dan and others have referenced. The financial situation isn't going to get better overnight. So we've got to really hold on to some of our principles. And the organisations that can take risk need to take risk. And again, back to your power imbalance, there's only the ability to take risk is completely different across the different types of organisation in our local partnerships. And VCSE are much less able to take risk than some of the bigger organisations, and we need to be cognizant of that.
Okay, thank you. Ben, Rachel, anything you want to add in terms of the challenges of partnership working, or any other reflections on what your colleagues might have said? Ben?
Sure. Yeah, thanks. Yeah, I was just thinking, as just building on Matthew's point, really, that there's something about the culture as well, isn't there, in terms of valuing VCSE partners and as key contributors to the system, and sort of fellow leaders as well. And I think there are things that we can do to help support that, and how we build our decision-making processes, and to ensure that we have captured that sort of wider view. There's something about the structures as well, because interestingly, we have those power imbalances also in our NHS partners, in terms of everything from a massive trust that spans multiple counties and through to a small practice or community pharmacy or optometry practice or something like that it's a much different scale. And so one of the ways that in primary care practices, for example, are addressing that is by coming together through federated models or collaboratives and things like that. And then we've got a similar thing with the VCSE alliances and so on. So I think those sorts of things are really important to provide that sort of scale, and also that ability to sometimes approach risk differently, as Matthew was saying, by doing it sort of collectively at scale. And then, because there is a real practical problem with some of the ICB covering such a large geography, being able to actually engage with so many different partners. So it really helps with that if we can sort of chunk things up a bit as well. It's that balance between that and the local sort of approach as well in the neighbourhoods, which is the balance we've got to hit, I think.
Okay, thank you. Rachel, anything you want to add?
I think the only bit I would add is around our workforce and our people. And again, I know the conversation I was having with Kate when we met earlier was around how we really energise and get our young people engaged in wanting to be part of that volunteering kind of and community engagement, and then how we use them to build our workforce for the future. We know, nursing, midwifery, our colleagues in medicine, we're all we're having a hard time, and I think there is never a day goes past, is there, where we're not in the social media or the spotlight, even at the moment with industrial action from our colleagues. So how do we build our workforce that is as energized and as committed to delivering the care that we want to deliver, and use the opportunities that a partnership with the VCSE has to offer, so that our young people and our local communities are engaged early on?
Yeah, I mean, we all know the phrase, the only thing that's constant is change, and it's about how we sort of support people's well-being when all this is going on. I can only imagine what's going on with the ICB restructuring at the moment, just how challenging that is. Matthew?
Well, it just occurred to me actually while colleagues were talking that one thing we didn't mention actually was in the new world was the continuing role and to build on the relationship with the Alliance, actually, at that strategic level. And I think that's going to be really important for us to try and frame that relationship in terms of how does the VCSE engage with the different partnership models. And Ben's talked about neighbourhood health models. We know in the 10-year plan we got integrated health organisations mentioned. Yeah. We believe that place-based partnerships and whatever they may develop into are really important. So I think that strategic bit about how we frame that relationship at a strategic level to make sure that we understand the touch points is going to be really important. I think Stephen or you, William, mentioned at the beginning the refreshed MOU, and I think one of those priorities is to really understand that strategic commissioning model and how we work at a system level to get the right engagement models.
Yes, thank you for that acknowledgement. It's something certainly we feel very, very strongly. Just want to reflect back on one other thing that was mentioned. I think of you, Matthew, that mentioned it was the whole kind of thing about risk, and I think one of the things that's become very clear to us is the traditional role of the voluntary sector in terms of innovation and challenge is there, and we will continue to do that. But in order to do that, I think one of the things we need more of is support from the NHS, and investment is probably a better word in terms of enabling us to do that, and enabling us to do that in partnership. And I think that's a particular challenge. I mean, we all want longer term funding, but we know how challenging that's going to be in the current context where resources are shrinking rather than increasing. So I guess there's going to be some real kind of decisions to be made about is how do you release some of the resources necessary to support innovation, to enable risk happen in the context of all the kind of complexity that's going on.
Yeah, I think that's right. I don't think that's I think that if you take sort of innovation in its broader principle and say it's about transformation as well, that's something we strategically struggle with as an organisation at the moment in our annual planning round, in terms of how do you create some resource to do something different where you may have double running costs for a period while you're innovating and trying something new. How do you create that degree of financial flexibility in an environment that feels extremely financially constrained? And I think that's, again, one of the areas that we haven't been able to do because of finances. And as we go into being a more strategic commissioner, I think we have to challenge ourselves to say, actually, that is fundamentally part of our role. And even if that puts pressure on the rest of the system, and there is a need to have some flexibility in how we commission our contracts to allow change and innovation. I think that applies across the board, but particularly for the voluntary sector, as you've outlined, William.
Okay, well, thank you very much, all of you, for that. We're going to take a short break now, and we'll come back at 11, and you'll be in your breakout groups then. So can I just ask that, since we aren't going to be having any feedback from the breakouts, that you ensure that you hold on to any actions to take forward at place, and please keep Stephen informed so we can track them afterwards. So but one final practical point: to go into your breakout rooms, you'll have to actively choose which of the 3 rooms you go into. Now that should be obvious because they're place space, But they're open now, and the session, as I say, will start at 11 o'clock. Now time for a brief break. See you soon.
Hi everyone, it's Stephen here. If you're still in the main room, you should be able to find the breakout rooms by going onto the bottom bar of Zoom, but you might need to make it full screen to find the breakout rooms, but they are already open. And quite a lot of people, about half of the meeting, are already in there, but you do need to go and click on breakout rooms.
Yeah, if you
find
can't
the
see
one you
it, it's under more as well, just in case it's
Right, there you
on
go.
mine it is anyway. Yeah,
Thanks, Kirsty.
welcome. If anyone's struggling to find a breakout room, give me a shout.
I am. So
Who's that?
I'm Alice. So I don't know what other cast. I don't know where this Zoom thing is because I am on a full screen.
Okay, Alice, which room would you like to go into? Which of the areas?
I don't know because I can't see which are the
Okay,
areas.
so there's Buckinghamshire, Berkshire West, or Oxfordshire.
Berkshire West.
No problem. I'll put you in now. Hang on.
Thank you.
Kirsty, could you do the same for me in a sec as well?
Yeah, no problem. Oh, sorry, it's been quite glitchy. Bear with me. Every time someone leaves, it kicks me back up. Oh, right, Berkshire West, Alice. Sorry, who was that? Who just said that as well? Was
So
that
Helen Clark.
Helen? Hi, Helen. For Berkshire West?
Yes, please. Yeah.
Problem.
Hello, Amelia Foster here. It's not showing any of the breakout rooms for me either. And I've got it on the screen.
Where would you like to go, Amelia?
Sorry, I realised I've got two screens. I'm looking at the wrong one. Oxfordshire, please.
No problem.
I've not left.
Who hasn't left? Alice?
I'm still here. I'm
Oh, I did just assign you. Hang on a second.
Oh,
right.
that's what.
Again. I've done it again. I don't know why you're still here, Alice. Ellen, do you need any help? Or Coralie? Or Bobby? Bobby, do you need a hand with assigning anywhere?
Oh, no, sorry, I missed the question.
Oh, no problem. Do you need me to assign you to a breakout room?
Oh, yes, I think so. Yes, I'm in with Bucks.
Lovely. I'll put you in it now.
Thanks.
Ellen, Coralie, I think you're on mute, but if you can hear me, you can let me know. Oh, okay, Coralie, you're leaving. No problem.
Hi, Kirsty.
Hi, William. I've just got an Ellen who hasn't.
Yes.
They've not. I can't get hold of them. I'll assume they've had to nip off for a minute, but I've sent a message to see if they need help.
Thanks for doing that, people. There's inevitably something happens with these things.
I know. And you can never know what someone else's version of this looks like as well.
No,
That's the hard part, isn't it? I might just bob into the Buckinghamshire room, but I'll keep an eye on the chat for Ellen.
Do you know what place Ellen is involved with?
No, otherwise I would put her in. No, it doesn't show me anything.
Right.
No, I'll wait to see. I'll quickly nip in and see if there's anything needed.
Okay. Thank you. I shall see you later then.
William, are you there? They'll be back in 4 minutes, won't they?
Okay, so do the rooms shut and then they come back automatically? Is that how it works? Okay.
Yeah, but or I will just remove them probably, actually.
You can enjoy that bit. Back in the room.
Oh, I might just go and give them, I'll go and give them a 60-second countdown, and or I'll say, I'll just bring you all back. Okay, see you in a minute. Weirdly, whenever I post in the chat, it says I'm Stephen.
I said what?
Very odd. No idea. It wouldn't be an assembly without a technical glitch, would it?
Oh, no. Well, if we only have one, we're doing well. Yeah, well.
Nearly done.
Yeah, I think no matter how well the developers think they've designed these things, they don't take account of user
Error.
comments.
I was reading something the other day that was quite funny. There was a guy, he was saying, you know, all the automatic note takers that join meetings now. He was saying that they all join as soon as the first person joins the meeting. So he likes to join and say something like, this morning I single-handedly rescued 25 women and babies from the Titanic. And then everybody joins and he stops. And then when they get the roundup of the meeting, it'll say like, Matthew's been dealing with the figures from Q2 whilst rescuing. Love it.
Yeah.
Very
Well,
clever.
the health service doesn't, NHS doesn't allow them. I know because I'm a governor in a local foundation trust.
Yeah.
I say very clearly to people, no, you can't. They actually won't accept them.
Yeah, I think it's a confidentiality thing as
Oh,
well.
absolutely. Yeah.
It is, and there are some bona fide ones, but there are also lots of slightly dubious ones. Right, I'm going to close all the rooms now.
Okay.
All right, that gives them 60 seconds. Amazing. That saves everyone trying to find their way back as well, I think.
Oh, yes, absolutely, yes. Here they all are.
Good stuff.
Lisa.
Hi there. did well there, Dan. You ended, I think, it was about 2 words, two words short. So
yeah, yeah, that was all right. Cut off in my prime.
Well, surprised, Dan, you weren't talking at the end, were you?
You know me, Matthew. I have to have the last word.
Right, welcome back, everyone. So in our last 15 minutes, we're going to hear from Matthew about the transition to Thames Valley ICB. Matthew's worked in BOB ICB from its establishment and has overseen the place partnership at chief officer level. We included the letter from CEOs of BOB and Frimley ICBs in the meeting paper, along with a slide deck. And you're invited to provide input and thoughts on the move towards the TV ICB. So please do so. So I can't quite say that, TV ICB. Anyway, so and since this is likely to be our last VCSE Health Assembly for BOB, you know, it's important that you provide the kind of any relevant feedback. We're already talking to our friends in the Frimley Alliance about how we evolve to a strategic VCSE partners for the new Thames Valley ICB. So, Matthew, over to you.
Thanks, William.
Future. Have you got your crystal ball?
Yeah, it's all under control. So I'll just give and I don't know if Ben and Rachel may come in and give their perspective on it, but I'll try and keep it relatively high level. Dan started the session by explaining some of the changes. So at a practical level, we've been told to reduce our cost base and our staff base by 50%. That's all ICBs have been told to do that. So that requires effectively a change in what we do, a consolidation of resource, and unsurprisingly, as part of that consolidation of resource, number of ICBs has looked at their footprint to say, actually, can we make economies by operating on a bigger footprint? And I don't think it's a great surprise to many that actually, as part of that, we explored the BOB and Frimley relationship and came up with the suggestion that we move to a Thames Valley Integrated Care Board. So that is effectively making Berkshire whole and joining Berkshire with Oxfordshire and Buckinghamshire in terms of the integrated care boundaries. And all these, Dan also mentioned wider changes in the public sector. And one of the things we think is likely to be a benefit of that change is alignment with local authority, strategic authorities. Now, we don't know the answer to the local authority geography at the moment, but we suspect it will be Thames Valley-ish or close to Thames Valley. There may be a slightly different bit of the geography that we need to consider, but actually, I think in terms of a direction of travel, it's broadly sensible. And no, it doesn't include the Surrey part of Frimley or the Hampshire part of Frimley is Berkshire, the Berkshire part of Frimley. So we're working together that as a shared goal. And sorry, I'm just answering the questions as they pop up. Milton Keynes, no, we're not discussing Milton Keynes coming into that either, so it won't include Milton Keynes. So we think it's just a logical and sensible geography, and probably more logical and sensible than the previous model, if I'm being completely honest. So it seems sensible. So then it's about the process of organising how we create an organisation that can fulfil the functions and ambitions that we need to fulfil, and that's a challenge. So we've done some early work to think through, given the model ICB blueprint work that came nationally. We've talked about some of the key functions, and we're starting to think around the roles and responsibilities of those. So you've seen those in the pack, but unsurprisingly, there's a big focus on population insight, quite rightly, into how we get that right data and insight. There's sections around clinical leadership, and there's sections around commissioning strategy and planning, as well as sort of the corporate operation of the ICB. There are still a number of questions that are quite fundamental that we're expecting additional guidance on, where the ICB undertakes perhaps not a pure commissioning role. It's perhaps a bit closer to clinical services, so continuing healthcare, medical medicine optimization, safeguarding roles are rolled in the SEND partnership, where it's not completely clear yet what the new role would be. So we're We're inputting in some of the national debates, and we're expecting further guidance on a few of those really quite tricky areas in terms of how we develop the organisation. And in terms of moving to a strategic commissioning organisation, I think it's important that we do elements of strategic commissioning now, but I think the emphasis is how do we move more away from tactical work to more outcome-based work, better, as I said earlier, better informed by data, and also how do we empower the partnerships within that? Because I personally think the only way that we can create an organisation of that size with that reduced capacity is to empower other parts of the system to deliver and support us, so we can take a step back. So some really interesting debates there about how we interface with places as we know them, neighbourhoods as we develop them, provider collaboratives as they develop as well. So really interesting and challenging set of questions that we've got to work through. In terms of a timeline, we're in the midst of thinking around some of that organisational design at the moment, which is why we've written out to stakeholders asking for thoughts and input. When we've done some more work on that and sort of have draft structures and thinking, well, we'll do another session and staging of the engagement work as well. That's probably all I'm going to say, William, if that's okay. I'm conscious that probably talking to the audience, people will have quite a different understanding of what's going on. So again, I'm happy to answer questions and just give Ben or Rachel the opportunity and come and add anything from your perspective that I should have covered, because I did that. Really, that was just my initial overview. So I don't know if I pitched that quite at the right.
Thanks, Matthew. So while anyone has any pressing questions, and we'll sort of try and fit in as many as we can the time we have available, please do pop them into the chat. Rachel, anything you want to add?
So, I mean, I tried to summarise this rapidly, a bit like Dan. I was sort of almost cut off in my prime at the end of the breakout group, but I think the two key takeaways for me from the conversations are around the commitment from us across health and care to genuinely co-design and do good engagement with yourselves and with our partners as we look at new models of health and care into the future. So I really welcome that challenge and that debate. And then I think, as Matthew's already alluded, what do we mean by being a strategic commissioner of services, and how will that enable and empower commissioning more locally to our neighbourhoods and our local communities, and how do we develop services to do that? So again, I think that will be exciting as we work with colleagues on integrated health organisations, as those provider collaborations will mature, and as our partners within local government work differently. I think those commitments and those changes will be important for us to do. So I think two key points for me from the kind of takeaway from the local place-based conversations and the morning.
Okay, thank you. Ben, anything you want to add?
Thanks. Yeah, it just had sort of general reflections, I guess, really. Yeah, it's been really helpful morning. Lots of exciting sort of discussions, really, in terms of the opportunities around prevention. I'm struck that there are lots of partners here who, encourage various forms of physical activity to help a whole range of problems, including mental health and wellbeing issues. Also, partners who are involved in areas of work to sort of preemptively stop longer term issues such as bereavement impacting on long-term mental health and things like that. So there's a fantastic sort of a mine here, isn't there, to tap into to help us with our work to deliver those objectives in the 10-year plan. So yeah, really looking forward to continuing these sort of discussions in the future to work with partners to put it, make it a reality for everybody.
Okay, thank you. And Dan, any reflections you want to add at this point?
No, I feel William, I've reflected too much, so there really is nothing more to say. I think the more that I read the blogs and things like that, this constant change. If there's one thing that is certain for us in our system, is there is going to be constant change, and there's a change right now. There's likely to be changes in the future. I think someone said earlier, I think what we need to bear in mind, and I think it was Alice in our Berkshire West group, what we need to keep in mind is, in reality, the people and populations that we serve continue to be in the places that we all live in. And actually our health and well-being is determined not by just how they access their GPs, what elective care they need, what emergency care, but all of the stuff that's around that. 80% of our health and well-being is determined by stuff that has nothing to do with the NHS, and we really need to work really hard on building the trust, building the relationships, using the assets that are out in our communities to really make a difference. And those outcomes, someone else was talking about how we measure outcomes, really focusing on getting the best value. So that's getting the outcomes that those populations need within the resources that we all have. And so that's going to be the focus. And I think we're on a journey, and we've got a really solid platform to work from.
Okay. Matthew, there's a question in the about risk assessment.
It's a tough question. It's good.
Yeah, I'm keen to understand. Obviously, 50% reduction from your perspective is a big ask. So it's almost like, what will the process be of looking at the doability of all of that devolving? How's that going to work, and maybe something to consider?
Okay. Yeah, no, I think it's a really good question, and Jacqueline, and from the ICB's perspective, we'll be obviously doing our internal risk assessments of the changes. And that will focus on particular areas. I mentioned some of the areas that we're quite worried about at the moment in terms of some of the guidance in terms of how safeguarding and the like will operate in the new model. So it will be internal ICB assessments going through to our board around the deliverability. One of the uncertain areas of deliverability, I think, is how much our partners can step in to support us, particularly around our NHS trusts, the local authorities. So I think that's why engagement is really important, because I think some of our partners want to step in and support and effectively take more proactive roles in some of our traditional responsibilities, but that's going to take a little bit of time to work through. So a good question. We'll be doing it internally, but there are some challenges yet that we haven't managed all that risk, I think, is the honest answer at the moment.
Right. Another $64,000 question. How will we measure outcomes? Classic, Matthew. Any quick thoughts on that?
Well, I think that, to me, that is all about the ability of us to identify those outcomes and how we measure them. So I think that, to me, is about really having effective population health data and insights, so that we can create outcomes that are relevant to the population and focus on that. I think that's got to be the challenge. So I agree with Tim's statement that we've got to measure outcomes. But I think there's also a cultural bit there, if I'm being honest. I think we also need our Lord and Masters to focus on outcomes as well, because a lot of my role is downward pressure from the national team and our politicians on their manifesto deliverables, which are not yet outcomes.
Okay, we've got a few hands up. I think we're going to run over a bit in this, but I think we need to. So when I call you, if you could just kind of briefly ask your question, so we can fit in as many as possible. Katie Slade.
Matthew, you mentioned about partnership working. I'm concerned about partnership working because we found out about some changes to our services, to the Parkinson's services, through our good relationships with our nurses. I don't believe that we were going to be involved in any of the changes, consultation or partnership work until it was actually set in stone. The changes are indicated that they will be made by October, and I think if our nurses hadn't brought us in and involved, we wouldn't have been consulted. So I am concerned about partnership working and how real that is.
Okay, thanks, Katie.
Yeah, I'm happy to. Perhaps if you drop me a note directly, just on the specifics of that, we can look into what went wrong with that in terms of our role. Well, I think it's helpful to learn.
If I can take it, somebody can pop an email. That would be fabulous. Thank you, Matthew.
Okay, thank you. And Alison Wilding.
Plea for outcomes, Matthew. I'll be really brief. So data requirements from the people giving the funding on the ground what is meaningful. That's a translation piece. We need to get really clever about going, okay, you've got this data which indicates this, which means you think you want this tick box outcome. On the ground, we use this language, and we just need to do that translation piece, because that's where things get stuck so often, and where things get commissioned that aren't those services that have evolved within the community. And that translation piece is the key to that. That's my absolute plea.
Okay, thank you.
I don't think that needs a response.
No, absolutely
I
not.
disagree with that. I hear it.
Okay, and Stephen, any final thoughts from you?
Yeah, I just wanted to signal a few things that are coming up. So our VCSE Alliance steering group has got a session about the design of the future Thames Valley ICB coming up in August. We've got a discussion with Dan about places and communities coming up. The key way for all the VCSE organisations that are here to be involved is through the action groups. That's where you can get regular involvement. So we do these VCSE assemblies twice a year. You can kind of keep in touch. You can hear where things are going at key sort of turning points. But to be really involved, you need to be in the VCSE Alliance action groups quite regularly. And those are coming up on the 10th and 11th of September. And Kirsty has miraculously put in all the links at exactly the right moment. So do follow those and come to those, because that's the way of keeping in touch and feeding your thoughts in. And then the people who are co-chairing the VCSE action groups go to the steering group. The steering group has the strategic discussions with Dan and Matthew and Rachel and Ben and all the others that we work with at the ICB.
Okay, thank you. Well, time to wind up, I think. Can I just finish by saying thanks to all our contributors? I think you've generated, I think, a really kind of rich discussion, and I'm sure you had sort of detailed place-based discussions in your breakout groups as well. So look forward to any feedback on those, because I think one of the important things about those discussions is hopefully you have some actions that you can focus on that will come from them. So time to wind up. We're just a few minutes over. Thank you very much for everyone for joining us and for sticking with the technology. I know how kind of challenging it can be sometimes, particularly when we're splitting up into smaller groups. So thank you. Have a great summer and take care. Bye.
Thanks, everyone.